Good morning. My name is Dr. Garth Fraga, and welcome to lecture number 2, Tumors of the Epidermis. I'm an associate professor of pathology and dermatology at Kansas University. First off, I wanted to confirm that I don't have any relevant financial relationships with commercial interests. So let's start talking about epidermal tumors. Epidermal tumors are very common. They're probably the number one cause of biopsy I see in my dermatopathology lab. And they seem pretty straightforward. I think most of us feel we have a pretty solid understanding of them. But the truth is that they're quite a bit more complicated than most of us are willing to admit. For example, actinic keratosis and squamous cell carcinoma are both very common diagnoses we've likely all made many times, but we probably all had that experience where it's very hard to tell whether it's an AK or a squamous cell. Likewise, keratoacanthoma is widely accepted by some dermatopathologists as a unique entity, and on the other hand, many feel very strongly that it's just a subtype of squamous cell carcinoma. Let's review how we're going to present the cases today. I'm going to go over some benign common epidermal tumors such as solar lentigo, seborrheic keratosis, hyperplasia, and malformation. Then we'll talk about the malignant epidermal tumors, and I like to divide them into those that are red and those that are blue, based on the color of the tumor at low power magnification. The red ones are actinic keratosis, squamous cell carcinoma, and keratoacanthoma, and the malignant ones are that are blue are basal cell carcinoma and Bowen disease. Finally, we'll wrap up with a discussion of 3 cysts that we see in the skin: the epidermoid cyst, the pilar cyst, and the proliferating pilar tumor. Let's start with solar lentigo, sometimes abbreviated SL. This is a hyperpigmented macule that's caused by sun damage. I like to tell the patients that they're wisdom spots. They kind of like that a lot better than liver spots. The word comes from a Latin word meaning lentil, and perhaps that's because of the shape or color of the lesion. These can be fairly large, and they tend towards coalescence. So you can see lesions that may mimic melanoma, particularly if they're more than 1 or 3 centimeters in diameter. Since they're caused by sun damage, you tend to see them on areas that get a lot of sun exposure: the dorsal hands, the forearms, the face, and the upper trunk. And they're incredibly common. Almost all Caucasians that have passed the 6th decade have solar lentigenes. And their primary importance lies in the fact that they can be confused with melanoma. There are dermoscopic differences, so a well-trained, experienced dermatologist using a dermatoscope really should be able to tell the difference, but we still see plenty of solar lentigenes sent in to rule out melanoma. On biopsy, solar lentigo is characterized by elongated reedy pegs that hang down from the dermis, and they have hyperpigmentation of the basal layer. These are sometimes described as dirty socks hanging from a line or hockey-shaped reedy pegs. And if you look carefully, you'll see that the tumor cells are all keratinocytes. All the cells that are making the pigment or hold the pigment are keratinocytes, whereas melanocytes are really pretty inconspicuous. This is one point of confusion in solar lentigo. Oftentimes you'll find this tumor grouped under tumors of the melanocytes, but it really isn't. It's really better thought of as a tumor of small, hyperpigmented keratinocytes, and that's why I included it in the lecture on tumors of the epidermis. Now, to have solar lentigo, you have to have solar elastosis. So all this clumped kind of lavender material in the dermis beneath the epidermis is solar elastosis. And usually it tends to assume this kind of clumped configuration when there's severe sun damage rather than the fine wispy elastotic fibers you'll see in minor sun damage. It's less perceptible, but usually the corneum is just very slightly hyperkeratotic. And like I said, the melanocytes are usually pretty inconspicuous. Some studies show a modest increase in melanocytic density, but on the whole, I think these are best thought of as tumors of pigmented keratinocytes rather than melanocytic tumors. There's a subtype of soil lentigo that goes by the fancy name of ink spot or reticulated lentigo. And this is kind of an interesting lesion clinically. It's not that distinctive histologically, but clinically, if you have a dermatoscope, it looks like a network of fine, very dark lines that are kind of crisscrossed across the surface of the epidermis. So a good dermatologist will sometimes submit a lesion as an ink spot lentigo. And you can confirm the diagnosis histologically by recognizing some subtle differences with routine soil lentigo. Most importantly, the pigment distribution tends to be heavy and concentrated at the tips of the reedy pegs, whereas the arcades, which are this part of the epidermis, at the top of the dermal papillae, tend to be spared pigmentation. This is why you have that reticulated or net-like pattern on dermoscopy, because they're looking at the skin from the surface. So when you have pigmentation in these reedy pegs, and you look at them from the top, it'll look like a network of lines rather than a smudgy brown patch. There's an interesting entity called large cell acanthoma, which some people think is a type of lentigo and other people think is a unique tumor entity. I did a study on these, comparing them to solar lentiginous, seborrheic keratoses, Bowen disease, and actinic keratosis, and perhaps somewhat to my surprise, I found that they did show a great deal of overlap with solar lentigo. The only thing that was statistically different between them and solar lentigo in my study was the size of the cells, which kind of makes sense since that's how it's defined. You'll rarely see a clinician submit the diagnosis of large cell acanthoma. You're much more likely to see a diagnosis of solar lentigo or seborrheic keratosis when you get these. But they are quite distinctive histologically. What you'll see is a very sharp lateral demarcation of the tumor from where it ends. This is normal skin. This is the lesional skin. And right at that junction, everything suddenly becomes twice as big. The cell nuclei are twice as big if you compare these lesional cells to these non-lesional cells. The cytoplasms are twice as big. The entire epidermis, the stratum malpighi, is twice as thick, and even the corneum is twice as thick. So I tend to think of these as solar lentiginous with cellular hypertrophy. Now, I have to admit that I'd have some doubts as to whether this really is just a solar lentigo or if this could be a unique lesion. There are reports of large cell acanthoma evolving to Bowen disease. I have rarely seen transitional lesions myself, and some cases do show a little bit of mitotic activity in cellular atypia. In those instances, I do recommend follow-up cryotherapy ablation. Seborrheic keratosis is super common. It's often biopsied because particularly family practitioners may worry that these represent melanomas. When you're walking around the mall and you see a patient with an unusual darkly pigmented spot on his face or back, particularly if there are multiple, it might cause you concern that it's melanoma. But these are just benign tumors of keratinocytes. The word comes from the Latin sebum or grease and the Greek horoia for flow, and we think that's maybe because they have kind of a greasy consistency if you rub them with your finger. They have many colors, tan to black. One thing that's very important clinically is they tend to be multiple. You wouldn't have 20 melanomas like this unless the patient had metastatic disease, but you would certainly have 20 seborrheic keratoses in one field like this. They really do come in any color of the rainbow, but they can be tanned. They're most commonly tanned to black. And using a dermatoscope, you'll find these little milia-like openings that correspond to the horn cysts we'll see on microscopy. They have a predilection for the upper trunk, head, and extremities, and they're associated with sun exposure. And there may be a genetic role as well, because it seems that they do tend to run in families. On biopsy, they're quite distinctive, and most pathologists really like these because we can look at them, make a confident diagnosis quickly. They're raised lesions, and they sometimes describe it as the string sign, and by that they mean that if you stretched a string from one end of the non-lesional dermoepidermal junction to the other, the tumor would lie above that string. Another very characteristic feature are these horn cysts. These are not true cysts, but rather they're infundibular canals or tunnels, and they open up to the surface like here. And this is what's responsible for those milia-like cysts that the dermatologists see with their dermatoscopes. The tumor cells that comprise this lesion are small and tend to be hyperpigmented, which is why they're brown or black clinically. Now, some seborrheic keratoses are problematic. One example is the irritated seborrheic keratosis. And I suspect that there are quite a few of these out there that have been misdiagnosed as squamous cell carcinoma. I have a relative who was misdiagnosed, who had an irritated sub-K that was misdiagnosed as a squamous cell carcinoma and was unfortunately not necessarily treated. How can you recognize irritated seborrheic keratosis and avoid misdiagnosis as squamous cell? Well, there are several clues. One, the cells tend to be epidermoid. They have large, abundant, dense pink cytoplasms, and they're closely stacked together without very conspicuous bridging sometimes. There's also a second component of cells. These small basaloid cells, they tend to grow in these little fascicles. They're slightly fusiform or spindled in shape, and usually they're sharply demarcated from the epidermoid cells. Squamous eddies are what you'll read about in the books, and they certainly are very helpful when they're there. And these are these little whorls of mature keratinocytes that don't keratinize at the center of the whorl. You can see there are several squamous eddies in this slide. Now, sometimes they will keratinize in the center, and this structure will resemble a keratin pearl of a squamous cell carcinoma. Now, there are some differences that are important to note between keratin pearls of irritated sub-K and those of squamous cell carcinoma. Most importantly, look at the appearance of the pycnotic nuclei inside the keratin. In a squamous cell carcinoma, which we'll see later on, the pycnotic nuclei are very dark and pleomorphic and irregular, whereas in a keratin pearl of an irritated seborrheic keratosis, either there are no nuclei, or when they are present, they tend to be kind of small and inconspicuous. A final important point of distinction are these cleft-like spaces that are produced by spongiosis. Now, this can be difficult because acantholysis is very common and a clue to squamous cell carcinoma and militates against seborrheic keratosis, but spongiosis leading to clefting is a clue to irritated seborrheic keratosis. Pretty confusing. Another subtype of seborrheic keratosis, which is sometimes lumped in with irritated seborrheic keratosis, is the inflamed seborrheic keratosis. This seborrheic keratosis has many of the similar features to an irritated sub-K. You have these keratin pearls that lack irregular pycnotic nuclei. You can have these somewhat epidermoid cells and basaloid cells, but there's a lichenoid inflammatory reaction indicated by the arrow here. And this is what makes this an inflamed or lichenoid seborrheic keratosis. You would use the same clues to separate this from a squamous cell carcinoma that you would use to separate an irritated seborrheic keratosis from a squamous cell carcinoma. Next is clonal seborrheic keratosis. This is another subtype of seborrheic keratosis, the last one we'll discuss. And it's kind of distinctive. It can be easily confused with other tumors because it doesn't usually form horn cysts. It's not so raised. It doesn't have the infundibular tunnels that the dermatologist can appreciate dermoscopically. Instead, they have these nests of basaloid spindled cells that tend to swirl or run in streams. And they're somewhat carved out of the epidermis. These can be confused with hydracanthoma simplex, but they're far more common than hydracanthoma simplex. Let's switch gears a little bit and talk about another common benign epidermal tumor, the benign lichenoid keratosis. Now, this entity is not really a true neoplasm or a true entity. It's actually lichenoid regression of a pre-existent benign solar lentigo or seborrheic keratosis. Clinically, these are solitary, dusky pink lesions that measure less than 2 centimeters in diameter, and there's a striking predilection for the upper chest of middle-aged and elderly women. In fact, more often than not, when I see a clinical requisition with a diagnosis of R/O BCC from the chest of an elderly woman, odds are it's more likely to be a BLK than a basal cell carcinoma in my experience. They do involve the arms sometimes, and their main clinical importance is that they often will resemble a superficial basal cell carcinoma. Patients will describe a history of change. They've kind of got that slightly reddish color and ill-defined borders, so you can easily understand why they might be mistaken for a superficial basal cell carcinoma. On biopsy, they look a lot like lichen planus, and some people will call them lichen planus-like keratoses. That's what Dr. Ackerman originally described them as. I prefer the term benign lichenoid keratosis myself, but feel free to use LP, LK if that's what you prefer. So they resemble lichen planus on biopsy. They show hypergranulosis,
keratosis, lichenoid inflammatory reaction with dead reds or dead keratinocytes, and the epidermis is somewhat squamatized, meaning it's lost the basal layer and the stratum malpighi keratinocytes are enlarged, polygonal, and closely packed with dense pink cytoplasms. There are a few little differences from lichen planus that will allow you to separate them in most instances. The keratin may be a little bit parakeratotic or abnormally red. The border between the epidermis and the dermis may be a little bit obscured due to infiltration of the epidermis by lymphocytes. But there are instances when they're absolutely indistinguishable. In those cases, even if it does come in as a rule-out BCC diagnosis or as a lesion, it might be worth alerting the dermatologist to the possibility it might be lichen planus. Even though it's much more likely to be a BLK, there's a chance it could be lichen planus, and it might be worth examining the patient for any other stigmata of lichen planus, such as nail changes, oral mucosa, genital skin lesions.